Hello, my dear. I'm Dr. Alaa Mosbah, Professor of Obstetrics and Gynecology, Faculty of Medicine, Mansoura University. Today we have an important lecture about small for gestational age fetus and growth restricted fetus, according to the Royal College of Obstetricians and Gynecologists Guidelines 2024. I have a previous lecture about fetal growth restriction or IUGR. You can find it in my YouTube channel. And this lecture will be restricted to the guidelines and some definitions. Okay? So you can find my other lecture and then go again to see this one. Okay? So what are the objectives of this lecture today? To know the definitions of what? An appropriate for gestational age, small for gestational age, and fetal growth restriction. There is three important definitions you should know. What else? The management of a small for gestational age fetus and the growth restricted fetus according to RCOG Guidelines 2024. So let us start with the definition. And please look to this chart. This chart, as you see, this is the 90th percentile, this is the 10th centile, and in between both, this is the appropriate for gestational age. So we call it AGA, appropriate for gestational age. This is the normal one. Fetus is one whose size is within normal range for its gestational age. And this is typically defined between 10th and 90th centile. As you see here, this is the 10th and this is the 90th. So in between here, this is the appropriate. What about if above 90th centile? This is large for gestational age. What if it is below 10th centile? This is small for gestational age. But in between, this is the appropriate for gestational age. Okay, the norm. So the second definition is small for gestational age, SGA. This is referred to fetus with the predicted weight or an abdominal circumference measurement less than 10th centile. As you see in this chart, below this curve here is a small for gestational age. This is zone for small for gestational age. So again, the definition of small for gestational age refers to fetus with a predicted weight or an abdominal circumference measurement by ultrasound less than 10th centile. Small for gestational age at birth is commonly diagnosed based on birth weight below the 10th centile. So if the baby is already delivered and if it is the birth weight is below 10th centile, this is also small for gestational age. Okay? But during antenatal care, you should depend on the predicted weight or estimated fetal weight or abdominal circumference by ultrasound. If it is below 10th centile, we call it small for gestational age. What is the definition of fetal growth restriction? Definition of fetal growth restriction in current pregnancy include one of the following. Estimated fetal weight or abdominal circumference below 3rd centile, or expected fetal weight or abdominal circumference below 10th centile. But you should add for this an evidence of placental dysfunction. Like what? Like abnormal uterine artery Doppler or abnormal umbilical artery Doppler Okay, so if I said below 10 centile, this is only just small for gestation age, but I cannot say fetal growth restriction. But if I add for expected fetal weight or abdominal circumference below 10 centile, an abnormal uterine artery Doppler or abnormal umbilical artery Doppler, this is a fetal growth restriction. Abnormal uterine artery Doppler, for example, mean pulsatility index above 95th centile and or abnormal umbilical artery Doppler absent or reversed in diastolic flow or pulsatility index above 95th centile. So I can diagnose fetal growth restriction, or I can define it in a current pregnancy if it includes estimated fetal weight or abdominal circumference by ultrasound below third centile. This is only can prove immediately the fetal growth restriction. No need for any more. Or expected fetal weight or abdominal circumference by ultrasound below 10th centile with evidence of placental dysfunction, as I said, abnormal uterine artery Doppler or abnormal umbilical artery Doppler. According to Delphi consensus-based definition, fetal growth restriction has been suggested for use both in clinical practice and in research. Okay, they divided the fetal growth restriction into two big categories: early onset fetal growth restriction and the late onset fetal growth restriction. If fetal growth restriction happened before 32 weeks gestational age, this is an early onset one. If it happened after 32 weeks, this is late onset fetal growth restriction. Of course, which one has a poor prognosis? The early onset fetal growth restriction. Okay? This table shows you the comparison between early onset fetal growth restriction and the late onset fetal growth restriction in absence of congenital anomalies. Okay? So I can diagnose, according to Delphi consensus-based definition, I can diagnose the early onset if abdominal circumference or expected fetal weight below third centile or umbilical or uterine artery abnormalities. Okay? In late onset, abdominal circumference or expected fetal weight below third centile. What else in early fetal growth restriction? I can use also the next: abdominal circumference or expected fetal weight below 10 centile combined with uterine artery pulsatility index more than 95th centile or umbilical artery pulsatility index more than 95th centile. So I have abnormal uterine artery Doppler or abnormal umbilical artery Doppler, either one of them, in addition to abdominal circumference and expected fetal weight less than 10 centile. What about late onset? Oh, I said before we can diagnose if abdominal circumference or expected fetal weight less than third centile, or at least 2 out of 3 of the following. 2 out of 3 of the following: abdominal circumference or expected fetal weight below 10 centile, abdominal circumference or expected fetal weight crossing centiles more than 2 quartile on gross centiles, cerebroplacental ratio less than 5th centile, or uterine artery pulsatility index more than 95th centile or umbilical artery, more than 95th centile. Okay, all women should be assessed at booking by 14 weeks for risk factor for fetal growth restriction to identify those who require increased surveillance using an agreed pathway. What is the risk factors for fetal growth restriction? A woman with a previous fetal growth restricted baby in a previous pregnancy, a woman with a previous preeclampsia in her previous pregnancy, or previous fetal demise, or has a medical condition that can affect the baby growth. So, all those considered risk factors for fetal growth restriction and need surveillance. When low pregnancy associated plasma protein levels, when low pregnancy associated plasma protein A levels or raised alpha fetoprotein levels and or raised inhibin A are incidentally detected following the first or second trimester screening for aneuploidy, it is recommended women should be offered additional ultrasound surveillance for gestational age or fetal growth restriction. Okay? You should notice this during screening for aneuploidy. Okay, what else? Women with low pregnancy-associated plasma protein A or raised beta HCG level, which are considered placental biomarkers and associated with adverse outcomes. Those women should be offered aspirin as persuasion. Okay? Aspirin can be given 150 milligram per day. When the following are identified on mid-trimester anomaly scan, like echogenic bowel, single umbilical artery, or expected fetal weight less than 10 centile, uterine artery Doppler should be carried out to assess the risk of early onset fetal growth restriction. Okay, what else? Women who have been seriously or critically unwell from COVID-19 should be offered an ultrasound scan to assess the fetal biometry. It seems reasonable to arrange the first scan within the first 14 days following recovery and to consider further ultrasound monitoring on an individual basis. Finding at the mid-trimester anomaly scan should be incorporated into the fetal growth risk assessment and the risk assessment updated throughout pregnancy. Okay, what about preeclampsia? Women at risk of preeclampsia and or placental dysfunction should take aspirin 150 milligram once daily at night from 12 up to 36 weeks of gestational age of the current pregnancy to reduce the chance of a small for gestational age and fetal growth restriction. Women should continue to take the recommended 10 microgram per day of vitamin D throughout pregnancy and the 400 microgram per day of folic acid pre-conception and for the first 3 months of pregnancy. However, we cannot guarantee that these doses or vitamin D and folic acid can, up till now, in prevention of preeclampsia or placental dysfunction, it is up till now it is uncertain. Okay, we should encourage the woman to stop smoking or reduce smoking during pregnancy by identifying women who smoke with the assistance of carbon monoxide testing and ensuring in-house treatment from a trained tobacco dependence advisor is offered to all pregnant women who smoke using an opt-out referral process. What about low molecular weight heparin? Should I give the lady low molecular weight heparin? Low molecular weight heparin shouldn't be prescribed to women whom fetal growth disorders have been diagnosed. So it shouldn't be prescribed if fetal growth disorder have been diagnosed. Okay, let us go to some clinical examination of fundal height measurement, symphysis fundal height ratio. Women who are at low risk of fetal growth restriction should have serial measurement of symphysis fundal height at each antenatal appointment after 24 weeks of pregnancy, but no more than every 2 weeks. Okay? When to start to measure symphysis fundal height? At 28 weeks gestational age. Okay? Every 2 weeks, you can measure symphysis fundal height. Women with single symphysis fundal height, which plots below 10th centile, or serial measurement, which demonstrates suboptimal fetal growth, should be referred for ultrasound measurement of fetal size. Routine measurement of fetal abdominal circumference or expected fetal weight by ultrasound in the third trimester doesn't reduce the incidence of an small for gestational age newborn, nor does it improve perinatal outcome. So it is not routinely done, abdominal circumference and expected fetal weight. Uterine artery Doppler should be carried out between 18 and 23 weeks gestational age plus 6 days for women at high risk of fetal growth disorders. And as I said before, who are at high risk of fetal growth disorders? Those women with previous fetal growth restriction, preeclampsia, small for gestational age, or stillbirth, or medical conditions, or abnormal biomarkers like pregnancy-associated plasma protein A, alpha-fetoprotein, inhibin A, and so on. In a woman who are at high risk with normal uterine artery Doppler and the normal fetal biometry at the mid-trimester scan, serial ultrasound scan for fetal biometry can commence at 32 weeks. Okay? Women with an abnormal uterine artery Doppler should commence ultrasound scan at 24 up to 28 weeks based on individual history. Okay? Clear enough? So those at high risk but normal uterine artery Doppler and the normal fetal biometry at mid-trimester scan, serial ultrasound scan for fetal biometry can commence at 32 weeks. But women with abnormal uterine artery Doppler should start the serial ultrasound scan yearly at 24 up to 28 weeks. Ultrasound biometry, fetal size alone is not sufficient to identify fetal growth restriction unless abdominal circumference or expected fetal weight by ultrasound is below the third centile. As I said before in the definition, as you remember, when I differentiate between the appropriate for gestational age, the small for gestational age, and the fetal growth restriction. Okay? Doppler velocimetry of uteroplacental circulation may be used to help distinguish between small gestational age and the fetal growth restriction in the third trimester. Why should I differentiate between small gestational age and the fetal growth restriction? Because the perinatal morbidity and the mortality is higher, of course, with fetal growth restriction, not small in case of small for gestational age. Small for gestational age may happen constitutionally or in some family. The baby is healthy but small. So, which is considered a risk factor for perinatal morbidity and mortality is the fetal growth restriction. So I should differentiate between fetal growth restriction and small for gestational age. When fetal growth disorder is diagnosed, an assessment of fetal well-being should be made to include discussion regarding fetal movements and computerized CTG where there are concerns. Also, a maternal assessment should be made to include a blood pressure and the proteinuria assessment. Clinical tests that measure placental growth factor, soluble FMS like tyrosine kinase 1, or the ratio between the two are now clinically available and recommended for the diagnosis of preeclampsia. Although small for gestational age or fetal growth restriction are strongly associated with preeclampsia and placental dysfunction, the use of placental growth factor and soluble FMS like tyrosine kinase 1 testing for the prediction and the diagnosis in non-hypertensive women is not routinely recommended. So it is not routinely recommended. So there is no abuse of such test. It's only for diagnosis of preeclampsia. Women in the moderate risk category are at risk of late onset fetal growth restriction, so require serial ultrasound scan assessment of fetal growth commencing at 32 gestational age, so 2 weeks gestational age for the majority of women, scan interval of 4 weeks until birth is appropriate. So you will start the serial ultrasound scan assessment at 32. Every 4 weeks you should do it. Maternity provider should ensure that they clearly identify the reference charts to plot symphysis fundal height, individual biometry, and estimated fetal weight measurements to calculate centiles. For individual biometry measurement, the method used for measurement should be the same as those used in the development of individual biometry and fetal growth chart. For expected fetal weight, the Hadlock 3 parameters model should be used. Maternity provider should ensure that they have guidance that promotes the use of standard plans of acquisition and the caliber placement when performing ultrasound scanning for fetal growth assessment. So you should measure the fetal biometry accurately and the quality control of image and the measurement should be undertaken. Ultrasound biometry should be carried out every 2 weeks in fetuses identified to be small for gestational age. Fetal biometry in fetal growth restriction should be repeated every 2 weeks. Assessment of fetal well-being can include multiple modalities, but must include computerized CTG and or ductus venous. In early fetal growth restriction, a woman's subjective assessment of reduced fetal movement or reduced or absent movement on ultrasound should prompt assessment with computerized CTG. Umbilical artery Doppler is very important. It's the primary surveillance tool and should be carried out at the point of diagnosis of small for gestational age and during follow-up as minimum every 2 weeks. Abnormal umbilical vein Doppler with pulsation may be seen in early fetal growth restriction and should prompt assessment of ductus venosus wave 4. What about middle cerebral artery, cerebroplacental ratio, or umbilical cerebral ratio? After 37 weeks, an abnormal middle cerebral artery or cerebroplacental ratio or umbilical cerebral ratio can be used to guide timing of birth, but not before 37. We should know that, okay? So it should be after 37 weeks. Normal middle cerebral artery or cerebroplacental ratio, umbilical cerebral ratio doesn't provide reassurance that the fetus is not compromised, and in all cases birth is recommended period to 39 plus 6 days, 39 weeks of course, plus 6 days. In fetus with an expected fetal weight between 3rd and the 10th centile, other features must be present for birth to be recommended period to 39 weeks gestational age. Either maternal, like maternal medical disease or concern regarding fetal movement, or fetal compromise, like diagnosis of fetal growth restriction based on Doppler assessment, fetal growth velocity, or a concern on cardiotocography. So we should recommend delivery period to 39 weeks gestational age. Antenatal corticosteroid should be offered to women between 24 up to 34 weeks plus 6 days of gestation who are at high risk of imminent preterm labor. Magnesium sulfate for neuroprotection and the prevention of cerebral palsy should be offered between 24 and 29 weeks gestational age and considered up to 33 weeks. For fetus with an expected fetal weight or abdominal circumference less than 10th centile, where fetal growth restriction has been excluded, birth or initiation of induction of labor should be considered at 39 weeks. After discussion with the woman and her partner or family, birth should occur by 39 weeks plus 6 days gestational age. No more than that. Okay? Induction of labor is not contraindicated in the small for gestational age fetus. Pregnancies with early fetal growth restriction, of course we know from the previous, you remember Delphi consensus definition, early onset fetal growth restriction those who occur before 32 gestational age, 32 weeks gestational age, okay? So pregnancies with early fetal growth restriction should be monitored and managed with input from tertiary level units with the highest level neonatal care. Of course, should include multidisciplinary team, including neonatology and obstetricians with fetal medicine expertise, particularly when extremely preterm. Extremely preterm, of course, those fetus before 28 weeks gestational age. When considering birth of preterm fetus with fetal growth restriction, particularly when very preterm before 28 weeks and severe, counseling of parents by an experienced obstetrician and the neonatologist should occur. Decision for birth should consider predictor of survival and morbidity. In pregnancies with late fetal growth restriction, birth should be initiated from 37 weeks to be completed by 37 weeks plus 6 days. Decision for birth should be based on fetal well-being assessment or maternal indication. This is the end of my lecture today. I hope it was helpful for you. Please remember, I have a previous lecture of fetal growth restriction or intrauterine growth restriction. You can find it. Please, you can see the previous lecture, then the guideline in this lecture. Okay? This is my box published on Amazon. You can find it if you go through this link or you search by my name, Alaa Mosbah. You can find my box on Amazon. Also through this link, you can find my lecture about obstetric and gynecology and quizzes and the guidelines. All of these can be found in my site on YouTube channel. I hope you got some benefit from this lecture. Thank you, everybody. My best wishes for all of you.